Dr. Amanda, Prof. Ronifas, can you hear me? My voice clear?
Yes.
Yes.
Okay. Now it's clear.
Okay, we will wait for Dr. Darmika to start again.
Yeah. Are you hear me?
Yes.
Okay.
No, very clear.
Okay. So Dr. Amanda, let's start the next your presentation.
Okay. Okay. So this is the point where I lose the connection, so I cannot hear anything. But I thought that probably Professor Fuss explained something here.
Yeah. So what I was saying is that based on a new definition of refractory GERD, this patient falls under the category of refractory GERD. But because the patient does not have any previous documentation of GERD, it's my understanding there's no evidence of GERD previously, then she falls more under the category of refractory heartburn. And in this situation, then the next step would be to take her off PPI and do a wireless pH capsule or catheter-based pH test of PPI. Am I correct, Amanda? There was no evidence before that she's got GERD?
Because she had the gastroscopy result, which show that she has a grade C esophagitis, that I decide that this patient has a proven GERD.
Yeah,
So
I agree. So impedance plus pH would be the proper test.
Yes, so we performed the pH impedance test on PPI at that moment. Sorry, not off PPI. So what do you think?
Yes, correct. So because the patient has documentation of GERD, she's got refractory GERD.
Yeah.
And it's the 2 months. You know, the old one was 3 months.
Yeah.
Here we have 2 months, but the new one is 2 months. So refractory GERD, impedance plus pH on PPI.
On PPI, okay.
It is useful to make endoscopy again after treatment.
What you're saying is that if she should be rescoped, we usually rescope to make sure that they don't have GERD. Especially grade C and D.
Okay, so
Dr. Amanda?
yes, Dr. Darmika. So if we are in the high resources, then we can go straight to the pH monitoring impedance. And this is, I know we cannot make a good conclusion just based on the score, but it's impossible for me to put the whole examination in this slide. So, and most of us in Indonesia doesn't have the facility to perform the pH impedance test, and probably what you get in your practice is the report, which show you many parameter and values. Probably we can get tips of which parameter can we use, which is the easiest to use if you have the patient report of pH impedance test. So in this patient, we perform a pH impedance test on double dose PPI, and the result is like this. I put 3 slides. The total reflux is still within normal. Also, the number of reflux periods, I think this was still within normal. Based on the line consensus, if less than 4% and the number of reflux event is less than 40, then it is normal. And this is Zerbib score on PPI. And then this is the symptom index and the symptom association probability, which is the symptom association probability is actually more than 65. So I think by chance it's a positive symptom association probability.
That's correct. It's above 90.
So is it GERD or? So this is GERD or reflux hypersensitivity.
So this is an overlap because the patient has GERD. We know that the patient has GERD. You get grade C. So she's got an overlap with reflux hypersensitivity. She's a little bit more complex because she also has gastroparesis in the background, we believe. And I'm not sure if we addressed the gastroparesis very well, if we took care of that.
Do you have next cases, Dr. Amanda?
Yes. So in this patient, Professor Fars, if I may have your advice, do we still keep the patient in a double dose PPI or because or should we do a rescope, like you said, to prove that the esophagitis is resolved and probably she doesn't need that double dose PPI again? And what do you suggest for the gastroparesis?
So, so for advanced grading of erosive esophagitis, it's okay to do double dose PPI. I would rescope the patient, make sure that there is complete healing of erosive esophagitis, make sure there's no Barrett's esophagus underneath. If you rescope the patient and the patient doesn't have any of those, you can try and see if you can step her down to once a day PPI. The only thing is there's always a risk that the patient will have some relapse of her erosive esophagitis. That's the risk. There's no question that we have to address the gastroparesis. So the patient has to go into a certain comprehensive plan to address her, which is, I think some of it was considered addressing her diabetes, lifestyle modification, proper diet, antiemetics, and maybe prokinetics.
Okay. Dr. Amanda, you finished first case?
Yes.
Do you have another case?
Should we move to the next case? Okay. Can you see a slide? How about now? Can you see the slide, Dr. Darmika?
Yeah,
Dr.
okay.
Darmika?
Yeah, okay. Okay.
Already shown the slide?
Yeah, that's okay. It's clear.
So this is the second case. In this case, we have a female, a 76-year-old female, came to the clinic because of heartburn, which had worsened over a 6-month period. The patient complained of intermittent heartburn, especially after there was also history of regurgitation and bloating and nausea. No history of vomiting, no history of difficulties in swallowing and coughing. No abdominal pain, no fever, no hair. Bowel movement was normal. He had lost approximately 10 kilograms of weight within less 4 months. He was diagnosed with GERD since 6 years ago and had gotten PPI treatment several times. At the moment, she was using a once daily rabeprazole when she came to our clinic. No history of hypertension. So she's healthy enough that no diabetes, no malignancy, and no routine medication. Both parents had GERD, no alcohol, no coffee consumption, no cigarette smoking, not in any particular diet. From the general appearance, she looks mildly ill. Yeah, still normal BMI, And then from abdominal examination, it's normal. And then the laboratory investigation is a bit high in the LDL cholesterol, but anything is within normal. So is this a refractory GERD based on her symptoms, heartburn, regurgitation, and weight loss? The refractory heartburn is defined as symptoms of reflux of gastric content that do not respond to double dose PPI of given for at least 8 weeks. So what is our next step? Do we treat it as a refractory GERD, refractory heartburn, or because of the weight loss, should we do the scope first?
Yeah.
Okay, yes.
So yeah. So we have a
Yes.
76-year-old gentleman with a weight loss, a history in the background of gastroesophageal reflux. Got worsened in the last few months. You have to scope the patient to make sure we're not dealing with a malignancy. I mean, that's the first thing you need to do. So endoscopy. So one thing against this is the fact that the patient does not have dysphagia. Usually malignancy in this situation is associated with dysphagia, but because of the weight loss, the heartburn, the age, I would scope the patient first. And would not
So,
consider
Dr.
this
Amanda, can you show?
Okay, so yes, I have to ask about this. Do we still have a role of PPI test in this patient?
At this point, I don't think PPI test is
Yeah.
an issue because the patient lost 10 kilogram. He's 76. He's got a history of heartburn. Definitely right now, I'm not concerned about PPI test.
Sure. So yes, but it's still done in our practice actually, because it's lower cost and not invasive. But yeah, we should know that it's not recommended anymore. But of course, formal PI therapy of evaluation is required for the treatment to evaluate the treatment response in good patients. In this patient, he performed the upper GI endoscopy, and what we found is reflux esophagitis grade A and a moderate erosive gastritis. So the doctor who treated this patient suggests to perform the esophageal manometry. So is it GERD? The gastroscopy able to detect signs of reflux with this complication, but if it's only A or B, then it's not conclusive for GERD, and we need another information like the presence of microscopic esophagitis. But we know that in our practice in Indonesia, we do not take biopsy routinely from a normal appearance esophagus, right, Dr. Danica? Should we take biopsy from a normal esophagus?
So we usually do in our place, and we do it not specifically to look for non-erosive reflux disease, but really to exclude eosinophilic esophagitis. In the rare case where somebody present with heartburn, and that's the main presentation of their eosinophilic esophagitis. He's a 76-year-old, doesn't have dysphagia. It's less likely the eosinophilic esophagitis at this point.
So we don't have to take a biopsy routinely from every GERD patient.
Hello?
If you look at the algorithm suggests that everybody should get wrong because of the clinical scenario that you presented.
Okay.
I think there's a buried esophagus in this patient.
No, it's not. It's
No?
only grade
No?
A esophagitis.
Do you have another?
Who performed who performed the endoscopy? Was it you, Amanda, or that was another physician?
Another physician in this patient.
Did they describe if they had difficulties to go through the esophagogastric junction, or I mean, I don't see, but I mean, this kind of information I'd like to hear about after the endoscopy. Sometimes just from looking at photos, you may not get that impression.
Yeah. So I did talk to the operator about this patient, and he said that no resistance to the esophageal gastric junction. Okay.
But he did suggest esophageal manometry, interesting.
Yes. Yes.
Yeah. Okay. Okay. What the result of manometry? Amanda?
So the functional testing is either pH impedance monitoring off PPI, on PPI, or always go straight to the high resolution manometry. Because at that moment, I considered this patient as an unproven group, then I first perform the pH impedance of PPI.
Of PPI?
Of PPI. No, not good. Because the grade A esophagitis.
Yeah, so I personally have problems with Lyon consensus. You are citing
Okay.
the Lyon consensus. I presented it. I have to. It's amazing how much we see the impact of the Lyon consensus on various other experts' papers. For example, grade B erosive esophagitis, in my mind, it's not inconclusive of GERD. I mean, because grade B could be anything that is above 5 millimeter. It could be an erosion that is 6 centimeter long. How could you call it inconclusive of GERD?
Inconclusive.
If you look at the refractory GERD paper, then you will see that actually they included grade B as conclusive because I told them that I will not vote for it if it will not enter back in as conclusive. And so grade B in the refractory GERD paper is considered to be GERD. Grade A, I agree. It can be whatever you see and whatever you feel that day.
Okay.
Yeah.
So unfortunately, I have to show you the pH impedance testing first. So, but this is the result of the pH impedance testing. Total reflux time is below 4, and the exposure number of reflux is less than 80. So I think it's not conclusive for GERD. And also the symptom index and the symptom association probability is not characteristic for GERD. So the next step is we perform the high resolution manometry, and this is part of the result. We can see that there's no normal peristaltic pattern shown in the procedure, and then the IRP is high, and with 10 watts fellows, all are failed peristaltic.
Your comment, Dr. Atlas?
So some of them So, I mean, when I look at this, some of them look like pan pressurization. I'm very intrigued to know if some of them I see like building up. And so sometimes what happens is that in patient, for example, with achalasia, as you ask them to swallow more water, they increase the intraluminal pressure and then eventually throw up, relieve it, build it up again. The IRP is definitely abnormally high. I look at your system, it's an MMS.
Yes, it's a
and you have to remember that the IRP, abnormal IRP for Labori MMS is higher than 23. The one example there is 40. So it's kind of, I consider it as high, even though it's an MMS. Oh.
Dr. Amanda, can hear me?
Yeah.
So
Dr.
this
Amanda.
is very suspicious.
Iya, Dokter Darmika.
Ya, putus-putus ya.
Yeah, I can hear you,
Putus-putus
Dokter
masih
Darmika.
tetap. Ya, oke.
Ya, gimana dok?
So,
Ya.
yeah, okay. What your next step for this patient?
So actually this patient is still a conservative treatment right now because he's afraid to take the next step of treatment. So no invasive procedure is done yet.
So one thing I would consider in this patient, Amanda, at this point, I don't know, it's something simple, it's time barium esophagram. And
Okay.
yeah, that's definitely I would do. You can do either endofleep, which I'm not sure is available.
No, not available.
Yeah, but time barium esophagram, I know it's available.
Yes.
You can do 1, 2, and 5 minutes, and you look at the emptying of the esophagus. I didn't hear anything about dilated esophagus. I didn't hear anything about problem going through the LES of the esophagus. So the next thing is to do is time barium esophagram.
Okay.
So, Dr. Amanda, you have another case?
No, this is the second case.
Professor Fas, do you have a general comment about these two cases?
I think these are very, I mean, the first case is very excellent case of a patient with refractory GERD that it's probably exacerbated by gastroparesis due to diabetes. This is something we recognize now more and more, that gastroparesis can lead to refractory gastroesophageal reflux disease. It's a much more complex patient from a management point of view, because it's not only about treating the reflux, but you also have to treat the gastroparesis. The patient was, in my mind, if I look at my patient with gastroparesis, was a little bit on the severe side. And also the GERD was on the severe side, grade C. We don't see a lot of grade C today. She also vomiting and lost weight. So it's a patient that definitely need a much more comprehensive approach. The second patient, it's also a very interesting patient in my mind. I think one of the things that we have to recall that it's not unusual that we mistaken achalasia patient as having gastroesophageal reflux disease. And in fact, one of the reasons that we have to do esophageal manometry before we offer patients anti-reflux surgery is to make sure we don't wrap achalasia, because that happened before. The heartburn that patient with achalasia develop is not the same mechanism as gastroesophageal reflux. It is more because of the stagnation of food inside the esophagus over a long period of time. In fact, when you scope patient with achalasia, you may find food in their stomach. It's not because they have gastroparesis, it's because there is a delay, a very, very long delay in food traversing their esophagus and dropping into their stomach. So I think it brings a very important point about, one thing is that we have to know, which I didn't see here, if you do pH impedance in patient with achalasia, there is a good chance that you will see nothing. Because in an achalasia patient, the esophagus might be full with liquids and fluid, and that will lead to almost flattening the impedance, and you won't see any changes. It will look like there is nothing there on your impedance. So that's another problem if you do impedance plus pH on a achalasia patient.
Amanda,
Yeah.
you will any question to Professor Fast? Do you have any question for Professor Fast?
Lot of questions actually. But I learned a lot today, Dr. Darmika. Thank you.
Okay. So because the time is a limit, so we close this session. So thank you very much for Professor Fast and also Dr. Armanda. So waktu ini saya kasih kembalikan ke MC. Thank you.
Thank you.
Thank you very much to moderator Dr. Darmika and also speakers Prof. Ronifas and Dr. Amanda. So now we will have a photo shoot. So please look at the camera. I will count in 1, 2, 3. Once more, 1, 2. Okay, thank you very much. Also, we would like to say thank you to our sponsor, ASI. And now please take a look at the coming video by our sponsor, ASI. To organizer, maybe you want to show the video again? Okay, ladies and gentlemen. Okay, ladies and gentlemen, now we almost get to the end of the session. For the next symposium is Comprehensive Situation and Management Update of Upper and Lower GI Disease, sponsored by Takeda. For this symposium, it will be moderated by Dr. Kaka Renaldi from Division of Gastroenterology, Department of Internal Medicine, Faculty of Medicine, Universitas Indonesia, Cipto Mangunkusumo National General Hospital. Without further ado, I would like to invite Dr. Kaka to please lead the session. Thank you. Dr. Kaka? Dr. Kaka, can you hear me? So, ladies and gentlemen, we'll still be waiting for Dr. Kaka as a moderator in this session. So while waiting, maybe the organizer can show again the videos of our sponsor for this symposium. It is sponsored by
Yeah,
Takeda.
Dr. Saskia, we can
Okay,
start now.
sorry. Yeah, okay. Dr. Kaka has already joined us. So please, Dr. Kaka.
Thank you. Assalamualaikum warahmatullahi wabarakatuh. Three speakers for this symposium. First will be Dr. Abi Norangga Pribadi, who will talk about endoscopic examination in IBD versus ulcerative colitis. Dr. Abi is very active in IBD and also field research is very yeah. Dr. Abi, without further ado, please start your presentation.
Thank you, Dr. Kaka, Mr. Chairman, for the kind introduction. Assalamualaikum warahmatullahi wabarakatuh. Thank you very much for the committee for assigning me to present about my presentation. I will share it to you first. Dr. Kaka, can you see my slide, Dr. Kaka? Okay. Dr. Saskia, can you see my slide?
Yes, Dr. Abi.
Okay. Thank you very much. I will talk about the endoscopic examination in IBD and how to differentiate Crohn's disease and ulcerative colitis. So for the introduction, IBD or inflammatory bowel disease is a chronic relapsing remitting immune disorder of unknown etiology that affects millions of individuals around the world with, of course, debilitating symptoms. This slide shows the main pathology before we do the endoscopy in patients with IBD. We should know the main pathology of each entities. These are the two main entities of IBD, which is Crohn's disease or CD and ulcerative colitis or UC. The main concept is in the Crohn's disease, the inflammation is transmural in nature, which means it is involving mucosa, submucosa, muscular layer, and serosal layer. And the extension of the lesion can involve any part from the oral cavity to anus. On the contrary, the ulcerative colitis is basically an inflammatory mucosal disease, yeah, mucosal and not transmural. And the extension of the lesions involving the rectum, and usually it can extend approximately and can involve the entire colon or the so-called pancolitis. These are the main concepts that we should keep in mind. The etiopathogenesis of IBD is very complex. It is involving genetics, environmental factors, intestinal dysbiosis, and immunological responses. Before I talk about the endoscopic findings of IBD, we should know the main presenting symptoms of complaints patients if he or she come to us. I took this from the study from Perler of 233 CD and 150 UC patients, that in CD patients, two main presenting complaints are fatigue and abdominal pain. In UC patients, the two main presenting symptoms are the passage of blood or hematochezia and loose or watery fecal or diarrhea. In this condition is termed as chronic diarrhea. These are the statistics that in Crohn's disease patients, they are often complaining of fatigue or tiredness, abdominal pain, or loose or watery bowel movement or diarrhea. In UC patients, the presenting symptoms mainly the passage of blood or hematochezia, loose or watery bowel movement or diarrhea, or urgent bowel movement or urgency. Okay, these are the we should know about the presenting complaints of IBD patients. What about the endoscopic modalities in IBD? What can we offer to patients? The endoscopic examinations, of course, colonoscopy, flexible sigmoidoscopy, but in clinical practice, we frequently use or utilize colonoscopy in order to intubate the terminal ileum to differentiate between Crohn's disease and ulcerative colitis. And then we can use also push enteroscopy using pediatric colonoscope or enteroscope. And then we can use also balloon assisted enteroscopy with selected indications, whether it be double balloon enteroscopy or single balloon or spiral enteroscopy. Okay, this is the main talk in this session. So before we do the endoscopy or colonoscopy, we should keep in mind these 8 characteristics that can be found in the endoscopy of the UC or CD patients. And the first characteristic, the rectal involvement. In UC, it's almost always involved, the rectal involvement, or we known as proctitis. In CD, it's frequent. It can involve the rectum, but not as always as a UC. The second characteristic is a small bowel involvement. In UC, it's rare to involve small bowel. Usually, we can see the findings of backwash ileitis, in pancolitis type of UC. In CD, the frequent findings involving small bowel. What about the continuous lesions? In UC, it's always continuous. In CD, it's infrequent. Nonetheless, in CD, we define the lesion as skip lesions, not or discontinuous lesions. And the depth of ulceration is mucosa in UC, and it's deeper than mucosa in CD, or the so-called transmural inflammation. In cobblestone appearance, it's findings in the CD, not in UC. Stricture is rare in UC and frequent in CD. Vistula is an abnormal connection between two organs or two cavities. It's not found in UC and frequent in CD. And perianal lesions is frequent in CD, in no and UC. These 8 characteristics should be evaluated when we performing endoscopy in IBD patients. Okay, these are the typical findings of the ulcerative colitis. We can see erythema, we can see the edematous mucosa and causing the loss of vascular markings, and we can evaluate the mucosal friability, and it's frequently associated with erosions, for example, ulcers, or even spontaneous bleeding. And in chronic inflammation, it can cause the luminal narrowing and pseudopolyps, which indicates the mucosal atrophy. Okay, let's proceed to the UC findings, yeah, the endoscopic findings in the correlation with the severity index indices. Let's see here in left side. This is the normal picture of the mucosa in colon, yeah, like this. This is grade 0, yeah, in the Mayo endoscopic score. We can see here that the mucosa is smooth, yeah, and the vascular markings is very prominent, yeah. This is normal findings. Or maybe in inactive disease in the previously diagnosed UC patients. In the picture B, we can see this is a mild disease, mild erythema here, in here, and we can still can see the vascular markings right here. Okay, so we can grade this patient as the mild disease, yeah, or Mayo subscore 1. And this one, the C picture is a moderate disease, which erythema or the marked erythema compared to this picture, and is graded as the grade 2 or moderate disease. And in the right picture is the mucosal ulceration. Here you can see, and these are graded as the grade 3. So this is grade 0, 1, 2, 3 in the Mayo endoscopic score. These are the mild findings, the mucosal erythema, fine granularity, and of course, we can see here the decreased vascular markings. And in the moderate lesions is a marked erythema, loss of vascular markings, and multiple erosions here. And in severe types that we can see the ulcers here. You can see the ulcers that very extensive here. Which I show you with the cursor. And this is spontaneous bleeding. So you perform the colonoscopy, you just inflate in a minimal amount of air that the mucosa is already bleeds. Yeah, this is spontaneous bleeding, and this is the pseudopolyps here. You can see here pseudopolyps in the ulcerative colitis with long-standing inflammation. This is a luminal narrowing, yeah, due to the atrophy of the mucosa. Okay. There are many indexes or indices to assess the findings of the colonoscopy. Previously, I defined the findings using the Mayo score, which is very simple, reliable, and valid also. But in the overseas, usually researchers using the ulcerative colitis endoscopic index of severity. From the A, B, C, this is the vascular pattern. This is a normal. This is grade 2, and this 3. And this for assessing the bleeding from picture D to F to G, sorry. And then from picture H, I, J, K is to assess the erosions and ulcers. This is one the Mayo score. So, ladies and gentlemen, when we are performing colonoscopy or endoscopy in IBD patients, we will assess the disease activity and the extension of lesions. And the findings on endoscopy is a subscore actually of all the Mayo score. So when we meet IUC patients, we must assess or define the severity, whether it's still frequency, this is a score, the rectal bleeding, and the findings of endoscopy, this one, mild, moderate, severe, and the physician's global assessment. And this Mayo score will be used throughout the treatment of the patient of UC to define whether the patient has remission or improvement in his or her symptoms. This is usually we use. The overseas studies, researchers also use a more complex index of severity, which is termed UCEIS. But in clinical practice, I, for example, seldomly use it because it's much more complex. We have to assess the vascular pattern, the bleeding, and the erosion ulcers. And this one is the Likert scale. And these are the definitions. And we have to sum it up to assess the severity of the findings. Okay, let's move on to the Crohn's disease. The typical endoscopic findings in UC is continuous, in Crohn's disease is discontinuous or skip lesions. In the UC, there are no cobblestone appearance. In Crohn's disease, there are cobblestone appearances. In the UC, there are no small aphthous ulcerations, which is arranged in longitudinal fashion. In UC, there are no small aphthous ulcerations. Okay, these are the pictures. So I can show you with this cursor that these are the longitudinal ulcers right here. Okay, this one also, it's arranged in the longitudinal fashion, not in transverse fashion. Okay, and this is a cobblestone appearance. This one, just like the stone. Yes, cobblestone is a stone that usually used in paving materials that is rounded, and it resembles like this picture, rounded like this. It's interspersed between the mucosa of the erosion. Yeah? And this one, the aphthous ulcer, this one, this one, this one, this one, which is arranged in the longitudinal fashion, longitudinal array. Okay, these are typical findings to differentiate CD from UC. Okay, what about the correlation with the severity index? Of course, when we use the CDEIS, this is the superficial ulceration, this is a deep ulceration, and then let's see here in the left picture, this is the aphthous ulcer right here. You can see here the small one. This is the large ulcers, yeah, up to 2 centimeters, yeah, the diameter. These are very large ulcers, more than 2 centimeters. Okay, according to CDIS or simple endoscopic score, this score is 10 because it's ulcerated and impassable stenosis. This one in the lumen is there stenosis, and this one also CDIS says CD score 3 because a large and extensive ulceration. Okay, this is summary, Dr. Kaka, actually, because the main topic is about differentiating in CD and UC. So before we're performing endoscopy, we have to know the clinical symptoms. The main symptoms in CD are fatigue and abdominal pain, of course, because of this transmural nature. And the main symptoms in UC are hematochezia and diarrhea, because in the nature of the inflammation is mucosal inflammation. And CD and UC must be differentiated endoscopically. And CD, this is the main points here, that in CD, we can find a cobblestone appearance, number one. We can find longitudinal ulcers, yeah, and we can find aphthous ulcers, which is not found in the UC findings in colonoscopy. In UC we can find erythema, and then erosions, ulcers, spontaneous bleeding. And the main principles, as in the UC, is a continuous lesions, but in CD, it's a discontinuous lesions, or known as the skip lesions. And the endoscopic findings should be evaluated and documented properly. It means that in UC patient, for example, we can use a documentation of the using Mayo sub-endoscopic score for the sake of its simplicity compared to the UCEIS. In the Crohn's disease, we can use the score of simple endoscopic score, SASCD, in sake of the simplicity also compared to CDEIS. Okay, I think that's all, Dr. Kaka, my brief and concise talk. I hope it's understandable, and hope for the next discussion. Thank you, Dr. Kaka. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Abi, for your very clear and very informative. Yeah, because it's very difficult to differentiate Crohn's disease and ulcerative. Just the pathology doctor define the difference between those two. Speaker, it will be Prof. Marcel, who will talk about the step versus step down management of IBD, how to start biologics. As you know, Prof. Marcel is very for IBD research, and also he has a lot of experience using biologic agents. Prof. Marcel,
Thank
please,
you, Dr. Kaka, as moderator.
further ado,
Yes, thank you. Thank you,
please start your presentation.
thank you, the organizing committee. I was chosen by the organizing committee to speak about how to start the biologics and how to give the biologic agents in this patient. So I will share first the have you already seen the slide? Not yet.
Not yet, Prof.
Sorry. Okay. Yeah. This is my topic: the step up versus step down in the management of inflammatory bowel disease. How to start the biologics. Uh, so this is my outline, and as you know that we have now increasing incidence and prevalence of inflammatory bowel disease in Indonesia as well as in the Asia Pacific region. And one of the treatments of IBD is biologic agents such as anti-TNF or anti-integrin or anti-interleukin. And the treatment approach that is now is very popular as the step up or step down, but the step down is more popular than the step up until recently. And this is the definition, step up, as therapy for inflammatory bowel disease gradually start with the lowest, the simplest, the more simple medication like Lymph 5 or ASA, Salazoparin, and then we change or increase with the corticosteroid or immunosuppressant. And if there is no response, we change to biologic agents like anti-TNF and anti-interleukin. And the second approach is the step-down treatment, which is big for the moderate and severe diseases. So we give directly the anti-TNF, the biologic agents, anti-TNF or anti-integrin or anti-interleukin. Then after that, after 1 or 2 years, we stop or we change to the simpler medication like 5-ASA or corticosteroid. Yeah. And this is the evolution of treatment goals in IBD. So we have to improve the symptoms. We have to make clinical remission. We have to achieve the steroid-free clinical remission, and we have to achieve the mucosal healing of the mucosa of the colon and the bowel. And also, we have to change the disease cause. That's our target until now, the recently target for treatment of the IBD cases. Yeah. And for this medication, we have 5-ASA, steroid, azathioprine, methotrexate, anti-TNF. So uh, the most good medication for IBD is biologic agents like anti-TNF, anti-integrin, and the other biologic agents. So this biologic agent can give clinical remission, can give steroid-free clinical remission, and give clinical and mucosal remission, and also reduction of the surgical risk and reduction of disability and reduction of damage because of the efficacy of the biologic agents. And we can see from this meta-analysis that biologic agent is good for improvement of mucosal healing and good for the clinical remission and for the to reduce the damage. But for this, the best is vedolizumab and infliximab is the best between these biologic agents. Yeah. And this, the clinical remission is best for vedolizumab and infliximab between these biologic agents. And this also the lowest risk for infection is vedolizumab, yeah, and tofacitinib in this study. So we must choose what kind of biologic agent that is the safer for our patients. And from this study also that there is a good clinical remission and mucosal healing with vedolizumab and anti-10F and ulcerative colitis. So there will be clinical remission, steroid-free remission, and also mucosal healing with the vedolizumab and other biologic. And also this one this study showed that there is improvement of the clinical remission endoscopic healing with the biologic agent and also the improvement of histologic appearance of this biologic agent. So there is benefit to give the biologic agents for patient with IBD. So this one also meta-analysis showed that biologic agent is improve the clinical remission, also the histologic, and also improve the mucosal healing, and also can prevent the colorectal neoplasia by the use of biologic agent. Yeah. This histologic normalization is better in biologic agent in ulcerative colitis here. Yeah. So, and if you compare the step down and the step up, a step down is better than the step up because the step down use directly the biologic agents and uh, decrease the complication and so improve the clinical remission and improve the mucosal healing and it prevent the malignancy of the patients if you compare to the top down or step down treatment. So there is better. So there is 30% with the step down. There is 30% primary non-response, yeah, and then also uh, if you use the biologic agents, there is problem that there is 30% primary non-response and 20% loss of response in first year of treatment of biologic agent, and also 13% annual loss of response of the use of biologic agent. Yeah, use anti-10F. So better you use the anti-interleukin therapy or we can use the anti-integrin therapy for this patient with IBD. Yeah. So this is the treatment. So with the biologic can start early and maintain long term and position appropriately with the biologic agent. This is the step up treatment, usually the same. Yeah. So there is better improvement with the treatment with top down approach. Yeah, how to start the biologics. So if you want to start the biologic agent, you must do the medical assessment first. Like, is there any congestive heart failure with the echocardiogram, or is there is there any infection or in the patient? You must test the hepatitis B or C before treatment, and you must exclude the tuberculosis before you start the biologic agent. And also, we do the other tests like complete blood count, complete metabolic profile, blood glucose, liver function, kidney function, lipids and cholesterol. Is there any HIV infection or not, and other infection? So we must exclude all of this comorbid infection before you start the biologic. Yeah. So also you have to exclude the cancer. So you must do the cancer screening, and then for the vaccine assessment. If maybe the best for vaccine is you can give the influenza, but for the other vaccine like measles, mumps, if you have the IBD, do not give this vaccine. How about the COVID-19? Until now, we have no study, but a lot of experts said that it is very important to give the vaccine COVID-19 if your disease is stable, but if your disease is not stable, still active, you must treat first, and then after treatment you can give the vaccine. And also, which one do you choose the right biologic? If you afraid of infection, maybe you have to choose biologic that cannot give immune depressing biologic agent. So if you use the anti-integrin, it is better because the risk of infection is lowest. And then you must get clear on your new health plan. Yeah, this is the test you need before starting biologic. You must exclude tuberculosis, hepatitis B, hepatitis C, and then you must do the liver enzymes. And not if there is increase of liver enzyme, so you can exclude. And then you check the complete blood count, lipids, cholesterol, blood glucose, and then is there any autoimmune disease or not? You check the ENA, and then is there any skin disease or not? So you must exclude this one. And so you must, if you want to give the biologic, you must understand first what kind of biologic do you want to give. Is there a risk of immunodepression? If there is a risk of immunodepression, so you will get infection like tuberculosis or hepatitis, relapse or other infection for if you give the biologic. And then so you must also understand what kind of medication do you have, biologic or biosimilar, and is there a contraindication or not? Yeah. How about the role of cytokine? So you must uh, also study about this biologic, about the role of the cytokine and the role for the patient with hepatitis and is how do you give? You must study about how do you give. Is there a subcutaneous injection, or you give continuous infusion, or what? Yeah, is this and if you want to give a vaccine, you must study first if it is contraindication in patient with biologic agent or not. Yeah, this is a question you must ask for patient if you want to start the biologic. So about understanding the biologic therapy, about what to do before starting biologic, and about how biologic therapy will work. Yeah. So you must also tell this the complication of this biologic to your patient, the family, and also you must tell how do you give the biologic and how about potential side effect of biologic. You must tell it to your patient and about what to expect after starting a biologic. Is there improvement of the mucosal healing or if there any side effect or not? Yeah. So in conclusion, ladies and gentlemen, the approach treatment of inflammatory bowel disease can be used both step up and step down, depend on the policy of national health insurance or payment system and severity of condition or disease. If you have the patient moderate or severe, you can directly use the step down, but only mild moderate, you can also use the step up. Yeah, and depends on the if the insurance in your country, like Indonesia, the private insurance uh, can pay for your treatment, but until now the national insurance cannot pay the treatment of biologic agent. And recently, step down treatment is the more frequent use approach. And how to start biologic? We have to do the medical assessment first and exclude infections, exclude comorbids, and we have to do the vaccine assessment and choose the right biologic for this patient. Thank you very much your attention, ladies and gentlemen, and then we give the time again to our moderator, Dr. Kaka Renaldi. Thank you, Dr. Kaka.
Thank you so much, Prof. Marcel, for very informative and very clear presentation. Because this biologic agent is relatively new for Indonesian doctors and will bring a lot of benefit to patients. So next, we will have our third speakers, Professor Dadang Makmun, who will talk about unmet need in the management of chronic constipation, the role of lubiprostone from clinical evidence to clinical experience. As we know, Prof. Dadang is now the chairman of Indonesian Society of Gastroenterological, and he is now the head of Department of Internal Medicine, Fakultas Kedokteran Universitas Indonesia. So without further ado, Prof. Dadang, please give your presentation.
Dr. Kaka, but of course, I'm very happy because you got well very soon, yeah. Very
Thank you,
soon.
Prof, for your
Today,
support.
you
For
start
your support.
to chair this important event this morning. So thank you so much,
Prof.
Ladies and gentlemen, distinguished faculties. Assalamualaikum warahmatullahi wabarakatuh. This morning, I'm very honored to share and to deliver a talk about the new promising modalities in the management of chronic constipation, lubiprostone. For Indonesia, it's really new because now already available in Indonesia maybe since 2020, even though in some other parts of the world, this lubiprostone is already available since many years ago. Slide, please. But again, I would like to remind you all slide, about the burden of chronic constipation for the community health problem. As we know that constipation is right now is a common GI disorder in our daily clinical practice, and also give a significant healthcare problem in the community. And even though the majority of patients with chronic constipation cases are aggravating, but not life-threatening, even debilitating. And finally, if we do not manage it comprehensively, this disease can impair our patients' quality of life. Dr. Kaka, I want to ask you can you hear me clearly?
Yes, I can hear you clearly, Prof.
Okay. So nowadays, due to the development of medical technology, the availability of medical centers, which providing the management for constipation, and then the availability of new treatment modalities and the available of information who most patients in the world, especially in our country, can access it easily. More patients are seeking for a cure of the disorder, even though the reality is not exactly easy, mostly difficult. This is the risk factor for chronic constipation. Usually female more prevalent than male and mostly affected the population above 40 years old, or maybe some patient history of abdominal or hip or perianal surgery. And this is very important because of their lifestyle, including sedentary life, lack of physical activity, and inadequate water and fiber intake. And sometimes this is unrealized even by the physician or maybe by the patient among patients with comorbidities and polypharmacy. For example, the very simple situation is in our daily practice, we doctors sometimes very easy because of course indication to treat the patient with antacid. And we know that aluminum containing antacid could finally lead to the chronic constipation. Slide please. Again, I would like to briefly remind us about the pathophysiology of chronic constipation. We know that this constipation divided into two categories. The first is secondary. Of course, it means that constipation condition caused by other comorbidities such as extra intestinal disorder, some metabolic diseases, neuropathy, or maybe drug effects. And then the majority one is primary or functional constipation. And this one is divided into four categories, including normal transit constipation, slow transit constipation, rectal evacuation disorder, and the last is the combination of slow transit and rectal evacuation disorder. Slide please. Yes, this slide shows us about some comorbidities or some circumstances that can lead to constipation. I have told before that the first is intra or extra disorder, including thrombosed hemorrhoid, colorectal cancer, endometriosis, anal fissure, which is the patient finally avoid for fecal evacuation because of the pain arising at the end of the anus. Stricture due to diverticulum, large rectocal, and maybe adhesion after surgical intervention. And the second is some metabolic disorder, including diabetes mellitus, hypothyroidism, lead intoxication, some patients with uremia, hypomagnesemia and hypokalemia, and hypercalcemia. And the last is myopathy and neuropathy condition. Slide. This slide shows about some medication that can lead to chronic constipation, including opiate, anticholinergic, some antidepressant, medication for Parkinson's disease, some sympathomimetics medication, and antacid, calcium supplement, iron supplement, and of course, sometimes unrealized using long term of antidiarrheal agent. And we have to look about the presence of alarm sign, including rectal bleeding, unexplained weight loss, patient with persistent nausea or vomiting, patient with iron deficiency anemia, prolonged fever, especially patient with abdominal mass. And again, all patients with chronic constipation at the age of above 50 years. Slide, please. This is the further investigation for patients with chronic constipation. Some diagnosis modalities are available right now in Indonesia, even though not all. The first is rectal balloon expulsion test, RBET. It is the simple maneuver, and then actually could be provided and could be carried out in all digestive clinic in all hospitals. Anal manometry, I think, is still very limited. We have, of course, provide this manometry examination in our hospital, in Dr. Ciptoman Hospital. Of course, endoscopy now widely available in Indonesia. And again, colonic transit test, the test using the pellet containing radio-opaque could be carried out, especially in all health center with gastroenterologists and radiologists, of course, all together to find out the patient is with slow transit, normal transit, chronic constipation. The phagography, to be honest, it is not easy to be carried out because not only how to carry out this examination, but also to provide the required equipment. It's not easy. Slide, please. And then finally, patients with chronic constipation try to treat themselves. Find any medication provided at the not only over the counter, but maybe because of these modalities already advertised due to social media, including many social media, then they try to use laxing and more available over the counter medication for chronic constipation. But in such treatment modalities for chronic constipation, if we look at the content, some of them are containing anthraquinone. We have to be careful because the long use of laxative containing anthraquinone can lead to what we call as melanosis coli. Melanosis coli is the deposition of melanin along the mucosa of because of the long use of laxative containing anthraquinone. Even though this situation is reversible, but of course, if this situation and again the patient might be finally can make the serious condition. Slide, please. And this is the algorithm of chronic constipation management. The first is, and we have to conduct the physical examination perfectly. Some patients require basic laboratory studies, and please consider the test for metabolic disorder, including diabetes mellitus, thyroid function, and to define, is there any abnormality in the organ, especially intra-abdominal. Of course, one of the most diagnostic modalities among all patients with chronic constipation. We can to initiate with the empirical treatment. Empirical treatment in lifestyle modification, especially diet. High fiber diet is still recommended in concomitant with laxative treatment, including secretory stimulants such as lubiprostone. Now lubiprostone already available in Indonesia with the name of Amitiza. And then I think our colleagues could try it because reports from other centers in the world showed the beneficial effect of this lubiprostone among patients. But if the response is inadequate, then the patient should be proceed for expulsion test. There are three possibilities: conclusive or abnormal. If abnormal, maybe the echography could answer the question. But if normal, proceed for colonic transit test. And finally, there is two results: slow transit or normal transit constipation. But if the result of anarchical manometry, barium, and the echography could be carried out. Slide, please. And how to treat among patients with chronic constipation, both slow transit and normal transit. Again, we can try with the lifestyle modifications. We can initiate it earlier with the use of some stimulant or secretory laxative, for example, including lubiprostone. Then if the response is good, we can continue the regimen therapy. But if there is no improvement, we have to repeat the colon transit test during medication. And if the result is slow transit, we have to consider the possibility of gastric emptying disorder. But if the result is normal, we have to adjust the medication if necessary. And then, if there is the gastric emptying disorder, then we have to evaluate this. Then the result is two categories, slow or normal. If normal, we have to try to consider colonic manometry. Abnormal, maybe finally the patient at the end require surgical intervention, even though this situation is very, very rare. We have to consider about what we call as subtotal collect, what we call is colonic inertia or lazy colon. Yeah. But if the result is normal, maybe surgical intervention still required with the what we call is temporary loop ileostomy. Slide, please. But this is the most important for our colleagues in the primary healthcare centers. How do we manage the patient with constipation? If they come to the primary health care centers, instead of good anamnesis, good history taking, and perfect physical examination, we have to look the possibility of alarm sign, whether the patient with the onset of more than 40 years old, the possibility of the secondary constipation, and then is there any abnormalities on digital rectal examination. If there is no alarm sign, we have to try, we have to initiate the empirical treatment, including lifestyle modification, fiber, high exercise, and the use of laxative, such as lubiprostone. Then we can continue the medication, but if the response is not good, then we can refer the patient into the higher level health center who provide further examination modalities, endoscopy for chronic constipation. This show us about the treatment option of chronic constipation, from lifestyle modification to the use of pharmacologic modalities, and of course non-pharmacologic treatment this constipation to arrange their diet, how to adjust their diet and lifestyle modification, exercise, and many other lifestyle modification, encourage them to reduce the use of laxative if they have already treat themselves with available diet and lifestyle, high fiber containing food, adequate water intakes is very important with the minimum intake of 30 to 50 cc per kilogram body weight every day. And we have to increase physical activity, daily activity, and try to adjust their bowel habit. Try to avoid straining and try to defecate after breakfast because we do believe that that is the maneuver that what we call is postprandial bowel movement reflex. It means the reflex to evacuate the stool with the peristaltic of the bowel just after taking some food. And the last is intervention using fiber and bulk forming agent. We can use osmotic laxative or stimulant laxative or secretory stimulant such as lubiprostone, prucalopride, but unfortunately still available in Indonesia. Some suppository probiotic report beneficial also, and the additional treatment modalities maybe they require surgical intervention. Slide, please. So this slide shows us about how the dietary fiber take a role in the management of chronic constipation. The WHO concluded that a high fiber diet may be protective against and there are a gradual increase in fiber intake through diet and supplementation to 20 to 30 grams per day with adequate fluid are recommended management of chronic constipation. Additionally, maybe some psyllium supplementation may be appropriate in the management of chronic constipation. Slide, please. This is some report conducted by Young et al. Young et al. Concluded that dietary fiber intake can obviously increase the stool frequency, spontaneous bowel movement among patients with chronic constipation. Slide, please. And then the similar study conducted by Gao et al. As the meta-analysis of some RCTs show that exercise may be a feasible and effective treatment option for patients with chronic constipation. Slide, please. What are drugs that are available in Indonesia as the part of the management of chronic constipation? The first is bulking agent or bulk laxative agent, including psyllium, osmotic laxative, including saline laxative, magnesium hydroxide or milk of magnesia, non-absorbable disaccharide such as lactulose, surgical alcohol such as sorbitol and mannan. The next is stimulant laxative, including bisacodyl, senna fiber, castor and sodium ficosulfate, and deoctyl sodium sulfosuccinate, lubiprostone, and now available in Indonesia with the name of Amitiza, recommended the use of twice consumed with food for 4 to 12 weeks. And this modalities proven among patients with chronic constipation. Some other drug modalities such as rectal enema, including recommended also as the additional treatment among patients with chronic constipation. And in such center like in Jakarta, we can provide the biofeedback treatment. Then let me lubiprostone. Lubiprostone is a member. Lubiprostone activate type intestinal epithelial cell, which can increase the secretion of chloride-rich fluid. Lubiprostone can use to delay gastric emptying and increase stomach volume. Lubiprostone has a low systemic bioavailability, has a rapid onset of action, and has a satisfactory safety profile and approved by FDA right now. Yeah. As the indication of bowel symptoms daily, but for chronic constipation, 24 microgram twice daily. And for opioid-induced constipation, the dose of 24 microgram twice daily. Slide, please. Then the pharmacology, we can chloride channels 2 present in the apical membrane of the intestine are activated by lubiprostone, resulting in the increased secretion of chloride-rich intestinal fluid and other channels secondary to maintain the cellular homeostasis. Slide, please. And our college this is the pharmacokinetics, the 9 to 1.4 hour, and then if you use in the elderly so we can use as the similar in adult patient using lubiprostone, but for pregnancy, women is still included in category C, and long-term safety data accumulating almost 8 years patient with the long use of lubiprostone. Slide. This study conducted by Fukuda concluded that lubiprostone showed to increase the weekly average number of spontaneous bowel movement and increase the quality of life, of course, among patients with chronic idiopathic constipation. And again, the similar study conducted by Lembo et al. Concluded that during 40 weeks of a label study, lubiprostone was well tolerated over 48 weeks in adult patients with chronic constipation. Slide, please. So our college, a multi-center, double-blind randomized trial of lubiprostone conducted by Johansson et al. They also concluded that chronic constipation treatment with lubiprostone produced a bowel movement in the majority of individuals within the 24 to 48 hours of initial dosing, as well as other characteristics associated with bowel movement. And the similar study conducted by that to be superior to placebo for increasing the number of spontaneous bowel movement and in improving stool consistency, and it reduced the straining maneuver, reduced the bloating and overall constipation symptom, which in this situation sometimes make the quality of life decrease among patients with chronic constipation. And Wilson and Ronske, their study concluded that randomized double-blind placebo-controlled trial of lubiprostone among patients with chronic constipation, irritable bowel syndrome, and opioid-induced constipation have shown is to be effective and free of serious adverse effect. This is the result at the right on the right side. Slide, please. And again, the study conducted by Cryer et al. Yeah. Cryer et al. Concluded that lubiprostone is generally well tolerated, maybe nauseous must interfere the quality of life among patients. Slide, please. This is about the side effect or adverse reaction of lubiprostone. And the next is how about the lifestyle modification among patients with chronic constipation. This is the interesting study conducted by Noor Eden et al. In Egypt, which they concluded that education on lifestyle modification leads to an improvement in the severity of the symptom of constipation and the quality of life among the elderly patient with chronic constipation. Slide, please. And then the next is how to manage chronic constipation in elderly population. The etiology of constipation among the elderly is various. Yeah, various. And then principle of treatment are younger patient, but more attention should be paid for the possibility of fecal action. And in such situation, this fecal impaction might, then it is not good if they carry out this maneuver in long-term situation. And stimulant laxative in the elderly should, of course, with caution. This is changes in the elderly who finally can lead the chronic constipation, including the decrease of propulsion of the stool, slow colonic transit, weak sphincter, and the decrease of sensory motor function among the elderly. And again, the impaired of reservoir function of the bowel to inside the lumen of the bowel. Slide, please. And this slide shows what kind of laxative could be used in the management of chronic constipation among the elderly. Some reports show that bulk and senna, of course, could be used, and then isotonic PAG, and some report also show the beneficial effect of lubiprostone among patients with chronic constipation in the elderly. Yeah. even though traditionally the first line pharmacological agent used to be lactulose, sorbitol, or senna, but some trials show that lubiprostone has the good outcomes in geriatric population in the term of efficacy and safety to manage chronic constipation in the elderly. Slide, please. This is some report about the use of lubiprostone in the elderly. Yeah, as we can take a look the study from Tomie et al. About the efficacy and safety of elobixibat, lubiprostone, for the elderly with chronic constipation, a multi-center retrospective cohort study. And this reported in 2020, they concluded that lubiprostone in this country, the name is elobixibat, for chronic constipation was confirmed to be useful and safe over a short period of time, regardless of the age, gender, underlying diseases, or concomitant medication. Slide, please. And this is the algorithm how to manage chronic constipation among the elderly. Of course, perfectly physical examination, and we have to carry out digital rectal examination, and we have to evaluate, is there any presence of alarm symptoms such as change in the stool, change in bowel habit, a hem-positive stool, fecal occult blood test, anemia, weight loss, abdominal pain, and maybe some abdominal mass. And then possible cause and consequence associated conditions such as medical use, concomitant diseases, history of surgical intervention, psychological state, and cognitive function and social support. And the first step, we have to rule out the organic causes of the underlying pathology cause and change the lifestyle modification such as much exercise, appropriate water intake, and then empirical medicine should be initiated for 2 to 4 weeks according to the constipation. Yeah. And the second step, maybe if necessary, we can finally to the center who providing this advice chronic constipation in manometry, balloon exposure, even though we can use in our digestive clinic in all around the country, and the defecation test. Slide, please. Our colleagues, I want to share about how to manage pregnant women with constipation. In these circumstances, the treatment of choice is, of course, high fiber containing food, increase the water intake, and prevent the symptom does not improve, does not improve, and any medication are used for a short period only. The bulking agent are considered more safe for the pregnant woman compared to the stimulant laxative, and bulking agent and lactulose are not absorbed in the intestinal wall, so it is safe for pregnant women and also in lactating women. How about lubiprostone? Lubiprostone is classified as the pregnancy category C. It means the studies of animal reproduction have shown an adverse effect on the fetus, and there are no adequate and well-controlled studies in human. Lubiprostone is recommended that any woman of childbearing age have a negative pregnancy test prior to initiating therapy, and be capable of complying to an effective contraceptive regimen. The use of lubiprostone during pregnancy can be justified only if the benefits outweigh the potential risk to the fetus. This is what they call this the category C. Slide, please. And again, some studies, study in Shanghai showed that the prevalence of functional constipation among pregnant women is Shanghai areas, about 13%, was higher than among the general population. And the pregnant women who were more than 35 years old with the pre-pregnancy body mass index more than 24, or who were highly educated and women with employed in the secondary occupation showed a higher prevalence of functional constipation. After pregnancy, almost all women take less exercise, which is one of the most common cause of constipation. So in this study, multivariate regression analysis showed that moderate exercise was a protective factor for the prevention of functional constipation in the elderly. This is some treatment modalities that could be used among pregnant women with constipation, including psyllium, docusate, sodium lactulose. Lactulose and psyllium are not absorbable in the mucosal on the GI tract mucosal wall. Polyethylene glycol, bisacodyl, and senna. Slide, please. And this is the last part of my talk this morning. What are the caloma? Harvicaloma can lead to the pressure of the intestinal wall, to the vascular compression, and finally diminish capillary perfusion, which followed by intestinal ischemia, followed by inflammation and necrosis, and finally stercoraceous colitis and ulcer formation, and maybe perforation. And the rectal distension can lead to could lead urinary tract retention, and the prolonged contact of the feces and the intestinal wall can lead to the mucosal irritation and increase the secretion, and will prolong internal anal sphincter relaxation and will decrease anal sphincter tone, especially in the elderly, and can lead to fecal incontinence and paradoxical diarrhea. The second possible complication, hemorrhoid. Hemorrhoid formation was found in almost for patients with constipation who underwent colonoscopy in our hospital. And the last complication, anal fissure and rectal prolapse. So we have to be aware about the possibility of this complication among patients with chronic constipation. Slide, please. And our college, Mr. Chairman, distinguished faculties, let me could impair our patients' quality of life. And then evaluation of patient with constipation should be begun with history taking, with the careful physical examination and further investigation that is tailored to one to each other. Medical practitioner in all around the country should be able to recognize constipation and the presence of alarm sign to ensure the appropriate management for every patient with chronic constipation. Enhancement of available diagnostic and treatment modalities such allow us to diagnose and to treat patients with constipation according to the available modalities in every center. And finally, lubiprostone is the new promising treatment modalities that has significant effect in increasing spontaneous bowel movement frequencies, and improve the quality of life among patients with chronic constipation. Slide, please. Thank you very much. This is the last slide that our society, Indonesian Society of Gastroenterology, has established this consensus in in the management of conservation. It's actually the revised one from the previous similar consensus. So thank you very much for the attention.
Thank you, Prof. Dadang, for very interesting presentation and very insightful presentation. I'm sorry, the signal is not very good. Now we move to discussion. We have so many questions already here. The first is for Dr. Abi, asking about, other than endoscopic finding, is there any laboratory test can use to differentiate Crohn and ulcerative colitis? Thank you.
Thank you, Dr. Kaka. I I will answer it directly. Actually, for laboratory findings, they are not no high accurate laboratory examination, yeah, to differentiate between CD and UC. For example, if you want to check fecal calprotectin, it only defines the inflammation in the bowel to assess the monitoring response to the treatment, but it cannot differentiate between the CD and UC. So the principally to differentiate those entities, we should combine the clinical judgment, endoscopic, and or radiology and histologic, Dr. Kaka. Thank you.
You said before that Crohn's disease can also mimicking like inflammation in the rectal, like the UC. How can we differentiate that condition between UC?
Oh,
Crohn's disease that affecting only the rectal.
yeah. So usually the recommended we should perform full colonoscopy first, and then in UC we will find, for example, if it's E1, E1 defines as proctitis. It's a localized proctitis, whether it's erythema, erosions, ulcers, yeah, and it's continuous lesions. But in the Crohn's disease, the involvement of the rectum, the findings might be aphthous ulcers with normal surrounding mucosa, such as like that, Dr. Kaka. So, in order to fully differentiate those two entities, full colonoscopy is required, Dr. Kaka.
Okay, thank you, Dr. Abi.
Thank you.
The next is for Prof. Marcel, asking about what is the preferred initial biologic agents. Is every biologic agent the same?
Okay, thank you, Dr. Kaka. Thank you for the question. I think we have to know first what kind of biologic do you have in your area, and what is the facility in your hospital, and then what is the economic status, and also is there any insurance of your patient. If your patient have no private insurance, I think they have to pay by themselves. And we have to know what is the price of one biologic agent. Yeah. If the patient also the patient has not much money, so we have to buy a biologic agent that is not so expensive. Well, we know that we have the first biologic agent is infliximab. Yeah, infliximab. The price is not so expensive as the last biologic agent, but infliximab has weakness that some of the patients, maybe 10 to 20%, will have in their long run. They will have antibody to infliximab, and then maybe in 1 year there will be 20% patients will get no improvement because of the antibody of infliximab. Yeah. But you must know how to give the infliximab by drip infusion, continuous infusion. Yeah? And if your patient have infection, maybe better not give the anti-TNF agents, because if your patient has infection, better you must treat first, and then you give anti-integrin, because anti-integrin, the risk of infection is not so high, so you can give anti-integrin. Yeah. Um, if you have if the patient has a contraindication, maybe you cannot give the biologic, and you must give the step-up treatment like 5-ASA or sulfasalazine, or maybe you can increase or combination with corticosteroid, or if no improvement, you can change to antidepressant or the other immunologic patient, immunologic treatment. Yeah. And depends on the facility and everything. Maybe you can give any medication for this patient. Thank you, Dr. Kakan.
Thank you, Prof. Marcel. So so the vedolizumab anti-integrin is the best choice for IBD with infection, yeah, Prof?
Yes, yes. The
Okay, thank
most,
you, Prof. Marcel.
yeah,
And
we can,
TVO, right?
yeah, Antivio, yeah, it's the best biologic agent, because there is no risk, or maybe a low risk of infection. Yeah.
Thank you, Prof. Now we have question for Professor Dadang. Uh, he asked about, is there any potential side effects for using Amitiza in long term, Prof?
Yeah. Thank you, Dr. Kaka. Some studies show that the use of Amitiza even until 48 weeks, yeah. So it means almost 1 year. It didn't show any significant side effect. And then in such study with the long use of Amitiza in the beginning until 8 years, there is no report about the significant side effect. But even though this is safe, of course, the use of laxative should be based on the established based on the evidence in all around the world, including in Indonesia. Yeah. Thank you, Dr. Kaka.
Yeah, and regarding that question, is it safe to use for IBD with constipation, Prof?
Yeah, of course. Yeah. We know that in such laxative could not be about the side effect of the use of Amitiza or ibuprofen among IBD patient. So if IBD patient required some laxative, I think uh, we can use it. And then, but again, usually most patients with IBD in IBS maybe, yeah. IBS constipation type. And then the dose of Amitiza only constipation IBS. Patient with chronic in constipation is twice 24 micro. Ya, Dokter Kakak.
Thank you, Prof. Dadang. So still considered safe, but we have to look for the indication first. Now, back again to Dr. Abi. There's a question about, is it possible
Kakak,
to find both characteristics of Crohn's and ulcerative colitis And what is the working diagnosis for such condition?
Okay, thank you.
Dr. Kaka,
Oh ya, ya Prof, silakan Prof.
Oh ya, Prof. Please, Prof. Maaf, Prof. Putus-putus, Prof. Ya, Prof. Please, Prof. Dadang. You want to say something?
of vedolizumab.
Oh yeah. We cannot hear you, Prof.
Yeah, I think what Professor Marcel already informed us, the beneficial of vedolizumab, the safety and of vedolizumab, I think is very important for us. Yeah, because before the agent will be given to the patient, we have to consider about the possibility of infection caused by the use of biologic. But again, I think vedolizumab is very safe because the mechanism of action is different with the previous biologic, such as infliximab or adalimumab. Yeah, this is anti-integrin. So my experience, if it is still on the study, show there is not only this is very effective and then in such patient until the mucosal healing, but also safe among patients with IBD, and then there is no significant side effect, including infection that arise after patient taking the biologic agent. So this is very important information for us, for the clinician, before deciding to use biologic among patients with IBD, I think. Thank you for Marcel for your lecture.
Yeah, thank you, Prof. Dadang. And the last question, Dr. Abi, please, can you answer?
Yeah, Prof. Yeah, Dr. Kaka. So when we performing colonoscopy or endoscopy, it's possible actually to discover lesions that is very ambiguous, yeah, or maybe to findings that mimically resembles whether it's UC or CD actually. For example, you can find any pseudopolyps not only in the UC but sometimes in CD. Yeah. But if you find any diagnostic confusion according to the endoscopic appearance, there's another entity in IBD which so-called unclassified IBD, Dr. Kaka. So in terms of diagnostic confusion, whether we cannot differentiate between both UC or CD, IBD unclassified precisely fit the condition, or previously called as indeterminate colitis, Dr. Kaka. But the endoscopic findings might be found to UC or CD in one patient. I think that's all,
And
Dr. Kaka.
regarding that classification, what kind of treatment can we use? What kind of treatment strategies? Is it for
Yeah.
UC or just like Crohn's disease?
Yeah, actually, the trial is not so many as UCD or UC, but standard treatments such as 5 ACEs for UC can be applied to those kind of patients, but still needs further study, Dr. Kaka. And I seldom find any patient with UIBD, yeah, unclassified IBD.
Okay.
Yeah.
Thank you, Dr. Abi.
Thank you.
The last question for Prof. Marcel. In IBD patients with hepatitis B, C, or HIV, is biologic agent absolutely contraindicated, or can it be used if those disease is controlled with medication like antiretroviral?
Thank you, Dr. Kaka. Yeah, usually we have to postpone the treatment with biologic, but we have to treat first the hepatitis B or HIV antiretroviral. Yeah, If there is already remission of the hepatitis B or the HIV, maybe we consider about how to use the anti-integrin, but not the other biologic. Yeah. The other biologic can decrease the immunological status, and maybe make the infection relapse or active again. So we have to be careful if you want to give this biologic. Maybe we need more studies to know if the patient is already remission in hepatitis B or hepatitis C, and also remission in HIV. Is it safe or not? We give the anti-integrin. But some experts said that, if already stable, we can give the anti-integrin. But we need more study about that. Thank you.
So theoretically, the safest for those conditions are vedolizumab or
Yes.
uh, Entyvio, yeah, Prof. Marcel, but still needs many research for this, right?
Yes.
Thank you, Prof. Marcel. Now the last question, Prof. Dadang. Uh, if the uh, if the response is not adequate with one therapy for chronic constipation, is there any consideration to combine more than one kind of laxative, Prof?
Question. Because if I have told you that nowadays more patients are seeking for cure to treat their symptom of chronic constipation. But again, the first step is should be lifestyle modification, including exercise, water intake, and many, many more. And the fiber diet, exercise, then laxative. Yeah. But before, before deciding the next step after using laxative and the response is not good, we have to evaluate is our diagnosis is correct. So why among patients with very difficult to treat their constipation symptom, the algorithm by all clinician, not only history taking, but of course, appropriation require laboratory examination, eliminate the possibility of secondary constipation such as metabolic diseases and many many other, and maybe anatomical disorder in abdominal cavity. Then after that, maybe some studies such as balloon expulsion test or maybe manometry could be carried out to finalize what is really going on with the patient. It is only slow transit constipation, or maybe normal transit, or maybe the most difficult is there is anorectal disorder. So in the last one, maybe again and again change of one laxative agent to another usually happen in the management of patient with chronic constipation. But we know the answer that the most difficult one is among patients with anorectal disorder, because modalities such as feedback and many many more, and maybe finally with surgical intervention is to combine two laxative modalities in the same time, but changing from the one to the other is maybe still possible. So this is finally the diagnosis should be really proven whether the patient is slow transit, normal transit, or maybe patient with anorectal disorder. Thank you.
Thank you, Prof. Dadang, for the answer. I think it's a very good answer. I think we can close this session. IBD and also itch treatments and also constipation now is oftenly, especially chronic constipation, is now oftenly treated well, and we have to know how to diagnose it and treat it very careful because it can lead to a very serious condition if we cannot treat it properly. So thank you so much, Prof. Marcel, Prof. Dadang, and Dr. Rabinu
Thank you.
for the presentation. And we hope that this is very useful for the treatment of our patient and for all of us. Thank you so much. Assalamualaikum warahmatullahi wabarakatuh. And I go back to the MC.
Thank you very much to Dr. Kaka and all speakers for very insightful symposium.
Waalaikumsalam
So
warahmatullahi wabarakatuh.
we will have a photo shoot, Prof. You may please look at the camera. I will count in 1, 2, 3. Once more, 1, 2, 3. Okay, thank you very much. And also thank you to Takeda as our sponsors. And now please take a look at the coming video by our sponsor, Takeda.
Constipation, defined as unsatisfactory defecation characterized by infrequent stools, difficult stool passage, or both, is a multifactorial condition that usually involves the interplay between colonic motility and fluid absorption or secretion in the colon. Chloride channels on the luminal surface of enterocytes play critical roles in intestinal fluid secretion and may be important targets for constipation therapy. Chloride channel 2, called CIC2, are transmembrane chloride channels found in the luminal cell membrane of intestinal mucosal cells. These channels perform several functions, including transepithelial chloride transport and fluid secretion. When activated, CIC2 transports chloride ions into the intestinal lumen, followed by sodium ions and then water. Lubiprostone is a locally acting CIC2 activator that enhances the secretion of chloride-rich intestinal fluid without altering sodium or potassium concentrations in the serum. The efficacy of lubiprostone is based on its action on the chloride channels in intestinal mucosa. After oral administration, lubiprostone activates CIC2 channels along the luminal cell membranes of the intestinal mucosa. The activated CIC2 transports chloride ions through the channels into the lumen of the intestinal tract. To maintain electrical neutrality, sodium ions follow the efflux of chloride ions via a paracellular route. Water is then driven via osmotic pressure into the lumen, also via a paracellular pathway. The net secretion of fluids into the intestinal tract adds fluid to stool. Furthermore, stimulation of local stretch receptors promotes increased intestinal motility. The increase in stool water content and the stimulation of colonic motility caused by lubiprostone both contribute to its efficacy in facilitating the passage of stool and relieving constipation. Finally, lubiprostone has also been shown to stimulate the recovery of mucosal barrier function and reduce intestinal permeability via the restoration of tight junction protein. Lubiprostone, the chloride channel 2 activator for the treatment of constipation.
Entyvio is a monoclonal antibody that has been developed for the treatment of moderately to severely active ulcerative colitis and Crohn's disease, two common forms of inflammatory bowel disease or IBD. IBD is associated with altered functions of the immune system. As part of the body's adaptive immune response, lymphocytes are imprinted for migration to areas of inflammation in specific tissues. Entyvio targets a discrete subset of imprinted T cells that preferentially migrate to the GI tract. The accumulation of such immune cells within this tissue contributes to inflammation that is characteristic of ulcerative colitis and Crohn's disease. As part of a process called lymphocyte trafficking, a small number of T cells are known to express the alpha-4 beta-7 integrin, which binds to the mucosal addressin cell adhesion molecule 1, or MAdCAM1. The binding of alpha-4 beta-7 to MAdCAM1 causes cells to enter the inflamed tissue from the vasculature. This interaction primarily occurs at the vascular endothelium in the lamina propria intestinal submucosa and gut-associated lymphoid tissue, the main sites of MAdCAM1 expression. Entyvio works by binding to the alpha-4 beta-7 integrin, preventing its interaction with its ligand, MAdCAM1. It selectively inhibits the adhesion of T cells to the endothelial surface of blood vessels within the gastrointestinal tract. As a result, Entyvio selectively restricts T cell recruitment from the vasculature into the tissue, reducing inflammation within the gastrointestinal tract associated with ulcerative colitis and Crohn's disease.
Okay, ladies and gentlemen, now we almost get to the end of the session, but before that, we would like to ask all participants to fill in our event survey, and the link has already been put on the chat room. So please fill in the survey form because your voice is so meaningful for us. And for now, for all participants, please turn on your camera because we're going to take photos together. So we're going to take several photos. Please stay still. I will count. In 1, 2, 3. Once more. 1, 2, 3. Okay, thank you very much. And finally, this is the end of the virtual Congress today. Thank you for joining with us, and we hope that this Congress will be very useful for all of us. We will continue again on the program tomorrow on 31st January 2021 at 8:30 a.m. See you, stay safe, and stay healthy. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Endoskopi ultrasonografi atau EUS adalah tindakan minimal invasif dengan menggunakan alat endoskopi yang dikombinasikan dengan pemeriksaan ultrasonografi. Dengan tindakan ini, kita bisa melihat lebih detail mengenai organ-organ di sekitar abdomen, di sekitar perut, seperti hati, pankreas, kelenjar getah bening, dan dinding saluran cerna lebih detail. Tindakan ini juga bisa dilakukan dengan menggunakan biopsi jarum halus, sehingga dokter bisa mendapatkan sampel cairan atau sampel biopsi atau mengeluarkan cairan dari dinding perut secara minimal invasif. Tindakan ini merupakan salah satu alternatif yang non-invasif dibandingkan tindakan pembedahan secara langsung. Endoskopi ultrasonografi diindikasikan pada kelainan-kelainan di saluran cerna, seperti misalnya kista di pankreas, atau cairan di pankreas, atau tumor di pankreas, atau kelainan di saluran empedu. Misalnya ada kecurigaan ke arah tumor saluran empedu atau batu saluran empedu yang masih meragukan, maka bisa dilakukan tindakan ini. Indikasi lainnya adalah tumor-tumor di saluran cerna yang membutuhkan pemeriksaan lebih detail, keterlibatan lapisan-lapisan saluran cerna. Juga bisa dilakukan tindakan ini.
Selama prosedur, perangkat ultrasound kecil terhubung dengan endoskopi. Endoskopi adalah tabung kecil bercahaya fleksibel dengan kamera terpasang. Dengan memasukkan endoskopi dan kamera ke saluran pencernaan bagian atas atau bawah, dokter dapat memperoleh gambar ultrasonografi organ yang berkualitas tinggi. Karena EUS dapat mendekati organ yang diperiksa, gambar yang diperoleh dengan EUS seringkali lebih akurat dan detail daripada gambar yang diberikan oleh USG tradisional yang harus dilakukan dari luar tubuh. Kapan EUS dilakukan? Pertama, untuk evaluasi stadium kanker. Lalu, untuk evaluasi pankreatitis kronis atau gangguan pankreas lainnya. Kemudian, untuk mempelajari kelainan atau tumor pada organ, termasuk kantong empedu dan hati. Kemudian, untuk mempelajari otot-otot rektum bawah dan saluran anus untuk menentukan alasan terjadinya kebocoran usus yang tidak disengaja atau inkontinensia. Dan yang terakhir, untuk mempelajari nodul atau benjolan di dinding usus.
Endoskopi ultrasonografi sudah dapat dilakukan di Pusat Endoskopi Saluran Cerna Rumah Sakit Pusat Cipto Mangunkusumo. Alat ini memang masih jarang didapatkan, memang hanya pada center-center besar seperti di RSCM.